So Dr. Vivian Ramsden is a registered nurse and a professor in the Department of Academic Medicine at the University of Saskatchewan. She completed a diploma in nursing from Holy Cross Hospital in Calgary, where she followed several years later with a Bachelor of Science in Nursing at the University of Saskatchewan, and a Master's of Science in Community Health Administration and Wellness Promotion in California, and then a PhD in Interdisciplinary Studies at the University of Saskatchewan. Her work has focused on underserved communities, including inner-city communities, Indigenous communities in Saskatchewan, incarcerated women, and rural communities in South India. This research has taken her across the world, from working with local communities in Sturgeon Lake, First Nation in Saskatchewan, to crossing continents for her work in Chennai, India. Regardless of her location, Dr. Vivian Ramsden has been on the leading edge of participatory health research. Dr. Ramsden was recently recognized by the College of Medicine and the Family Physicians of Canada as one of the top 20 pioneers in family medicine research in Canada for her work in helping to improve healthcare in underserved communities. And now Jackie Crowe is a Métis woman and a direct descendant of First Nations people. She is passionate about people and their health and well-being, and also the protection of the environment. She enjoys the company of her partner, Kevin. She's the mother of 4 adult children and has a number of grandchildren, both biological and adopted. She works as a caretaker and a janitor at a retirement home and enjoys the knowledge and stories shared by the grandmothers and grandfathers. She's been working with the Department of Academic and Family Medicine for the past 20 years, helping to build health programs for the communities. So please join me in welcoming Dr. Vivian Ramsden and Jackie Crowe.
So before we begin, Jackie's going to tell you a little bit about the history of our work, and then I'm going to actually go through a presentation. But the biggest thing for me is that without the community, it's not possible to do this work. So Jackie, do you want to talk a little bit about our opportunities that we started in 1997?
Okay. So how I got involved was I had a friend who had asked me if I would like to do surveys in our communities. We're in the 5 core communities. I lived in Riversdale. And I said yes, I would be very interested in doing that. And so we were invited to participate in meetings. We met at the, where was it? The community, was it the community clinic? For some reason I was thinking it was the Métis Center or something like that, downtown. And so the first few meetings were to discuss values. So the first thing we did was to talk about values, how we would treat one another, how we would treat our colleagues, and also the processes. So how we would treat one another in the group and how we would treat people in the community. And so those started with the values. And then once we had gone through the values, we had worked through the survey. An initial survey was created, and then we negotiated on what changes would be made to that survey that would be unique to our own community. So those things also had to be negotiated out. As you know, as researchers, that's what happens. You have to negotiate all these things out. And so Vivian was very vital in helping us negotiate those things. And so we had other things that we had to talk about, safety things, how we would go out in groups of 2 rather than individually, so there was safety issues. Phone cards were given, bus transportation, daycare, things like that. And we also had to negotiate payment for the work that we were doing as well. So there was a few steps involved there. And then we started, but the whole process took, I think it was close to a year and a little bit maybe, before we actually started going out into the communities and stuff. So the first year was meeting and getting to know one another and how we were going to work together and make this a good research project. So one of the things that I did like about it was we were asked a lot of questions. We were valued. That was a very important thing for me to see, hear, and feel within the work that we were doing. That we had knowledge and we had skills to do the work that we were being asked to do. So, and so after that, we went out, we did our research, meeting with the community members. We went to the doors. One of the things that we did do was we made the invitation. So we had randomly selected, or there was random addresses selected, and we sent the invitation out to those individuals, that was the first step. And then we would go to the door. So we had, I think it was 3 times we could go to the door to meet with that person. Now, if that person said, no, we don't want to meet with you, we were like, okay, that's fine, that's no problem. Thank you for your time. And we would go on to the next. And so it was very respectful in the sense that the people knew ahead of time that we were coming to the community. They knew and were prepared that somebody would be coming to the door and that they were being invited to participate. So after that was all finished, and that took quite a few months to get through all the 5 communities, we then had all the stuff sent to data and returned, and then there were programs created from that data.
Okay. Thank you. So in fact, what you heard was a community's vision of doing research. And they are peer researchers, your colleagues, and in fact they're engaged from the get-go before you begin asking the question. So I'm going to actually talk a little bit about theoretical constructs, and then we're going to look at how you might actually implement that into practice. So here are the things that you need to think about. Elements of patient-oriented research, but more importantly, how is this going to impact what you're currently doing? Because I don't want you to go away from here thinking that you haven't learned anything. I want you to think about it from the reflection perspective of how do you implement this into your own practice. So I know you're all familiar with the World Health Organization, and I also know that you're probably all familiar with the Alma Ata in 1978. So you all know that in fact all of this work is based on scientifically sound, universally acceptable, all of the community participating, affordable, self-reliant, and self-determination. Are those words ringing any bells around TRC, calls to action, or any of those things? This is not new. This is an opportunity for us to implement strategies in ways that are meaningful to and with the community. How many of you know about the new declaration that is just a few months old? This actually occurred in the same place that the Alma Ata occurred in 1978. But they're talking about disease prevention and health promotion. One of the interesting things that you know about the actual Alma Ata originally was that they taught those words, but there is no funding in our health system for disease prevention and health promotion. Interesting. Are we meeting the needs of the health of the people, or are we meeting the needs of the health of the system? And we need to start thinking about what does that really mean and how are the people involved, because it needs to be people-centered and gender-sensitive. What does that mean? That means that, in fact, regardless of what you think, you need to actually address the needs of the people. So a little bit more, carrying on. People know what works for them. How many of you are actually involved in patient care of some form or another? Okay. If you heard what the patient said to you, you're more likely to provide an opportunity that actually meets their needs. If you actually only think about the checklist or the pathway that's being applied, it doesn't often do that. But we actually focus all of our attention on pathways So for us to move to solidarity, ethics, and human rights, we have to move outside the box. So I'm encouraging you to think about how does the community, how does the individual own this information that they have. So we worked a long time, as you know. Jackie talked about our 1998 project, but more importantly, we've actually been talking about tobacco and tobacco misuse for a number of years. And so the actual strategy around primary health care is based on strengths. And so how many surveys that are validated are strength-based? Very few. They're deficit-based. Why does that happen? Because we as healthcare providers have a tendency to focus on what doesn't work rather than what does. How often is the individual and the community involved in deciding things? It's improving. Patient-centered care is a lot of talk, but the actual action occurs at the patient level with the healthcare provider. Can we do it better? And we want to actually have affordable technology. So I work at Sturgeon Lake First Nation, and for any of you who know where that is, it's out in the middle of kind of nowhere, and we have a lot of connectivity issues. So if we can't actually use our phones there, or our iPads or those kinds of things, it creates a double-tiered system so that we have to enter it one place, take it, download it, and put it into the medical system that we have there. So needless to say, programs and strategies often are developed into what feels good for us rather than working with people. And so we know that we all have the ability to solve problems. You do it every day, and so do patients. So let's actually start working together to solve a problem that makes a bigger difference rather than our solving the problem for someone else. So I wanted to talk a little bit about patients are experts. Everybody's talking the language, but really what does that mean? So Farah kindly sent me an article, and I looked at that article, but then I went to BMJ, and I looked at the article there that I've identified as Expert Patients Usher in a New Era of Opportunity, written by a Liam Donaldson. Do you realize it was written in 2003? This is not new. This is really old, but we're actually only getting to the point where we're implementing it today. So the research team is often comprised of a whole lot of researchers or clinicians coming together. Well, it now needs to include the team members that are community members or patients. And interestingly enough, the work that I've been doing at Sturgeon Lake, it's the Sturgeon Lake community that's involved around the table, and I happen to be the one, quote, outsider in that particular team. So I think it's a very interesting dynamic, and we need to start doing it in a better way. So co-creating research is the big deal. And if you've read anything from Tricia Greenhall et al., you will know that in fact she talks about co-creation, co-design, co-implementation, co-analysis, and co-transformation in terms of translating information into practice. It's a process. You heard that. We actually spent a year in the community in 1997-98 actually meeting with people in coffee shops, getting to know the community, getting to understand what was actually going on there. And so, interestingly enough, Jackie and I continue to meet about once a month, have coffee, and talk about what's new and what the new questions might be. And we talk about scalable and research projects, but you can't do that in the same way that you can actually scale up a project, because every community is unique. And so what you might do is do spread, so that you're looking at transferable aspects of that particular project to another community, but you still have to go through the same process. Okay? It's from the bottom up, it is not from the top down. Sometimes this hates me. Anyway, I just wanted to raise a couple of issues around ethics, and that being that we have to respect the community's culture and not our own. And so we need to build authentic, reciprocal, and trusting relationships that are not for the short time, but for the long time. So even when we have no research dollars, we're actually doing research. And so it's important for you to be thinking about how many communities can you support in doing that kind of work, because it's not just about the research project, it's more about a long-term commitment to that community. I've been working in South India with the 49 communities that I work with there since 1995. And I've been working with Sturgeon Lake for the last 15 years. And so I look at it and go, it's an opportunity for us to actually be present in and with the community. Holly Graham, a colleague from the College of Nursing, actually was really importantly identifying that in fact history shapes our current research. How many of you know about the helicopter research? You go in, you take the data, and you fly out. Familiar with that? It happens every day still. We haven't yet adjusted to this is not a good thing. So we need to think about what is it that we can do differently. And Willie Ermine, a colleague of mine at Sturgeon Lake, talks about the fact that it needs to be mutually beneficial. I shouldn't be asking those questions unless there's going to be a use for the answers when it actually comes. And we need to actually evolve, iterate. It's ongoing so that their questions and the results actually turn into another question, and so it goes. I've been doing participatory research for a number of years. And the biggest thing about that is that we're all equals. So everybody here is an expert. So is every community member. So is every patient that I see. And so in that partnership, it's about with. You don't go to a meeting and expect not to be heard. You go to a meeting and expect to be heard. So should the people in the community. So should the individuals that are at your table. I've talked about this already, but the one thing that I want to highlight here is power. And I want you to think about how it is that you're actually working together in a partnership rather than I'm giving my power away or, oh sure, you can take on that. The reality is we're equal. In a partnership, it's an equal opportunity, and so research is an equal opportunity team sport. Important, because in the end, it's that which makes it long-term. And Jackie talked a little bit earlier, but one of the things that we just finished doing was publishing a chapter in a book on how to do primary care research, which was published by WONCA, which is the International Family Doctors Federation. And so as a result of that, what we're really talking about, here's a process that you could look at and apply should you wish to. And so this particular book, I brought it here and you can have a look at it after. The whole goal is to minimize health disparities. I heard somebody talking about building programs for people earlier today, and I'm going to encourage you to think about how to build programs with the end user, with the people with the disease. Equitable, it's important, and in fact, in that process, we all need to write and we all need to share information. So again, it's really about moving forward in ways that are meaningful. So here's some elements around co-creation. We've talked about all of them. I just want to highlight a couple of them. One is provide ongoing support. When we were doing the community survey in inner city Saskatoon, we actually met once a week for 52 weeks, every week. And the only time we didn't was at Christmas. And we did it because we wanted to look and see that the data was okay, but more importantly, to provide support to the community members, because I was the only researcher, the community members were actually collecting the data. And so they needed to feel as though when they went to the door and something interesting occurred, that they had a place to talk about it. So we talked about all of those things. Consensus, do you know what that means? Do you apply it in your daily work? Do you anticipate that you've got a consensus agenda, a consensus meeting? Well, it's really important to be thinking about what does that really mean, because in the growing and the negotiating of it, you need to work together so that you actually have an end result that everyone can live with, not just the researchers. People need to learn things. When Jackie and I first met, we didn't actually come at it from the same place that she's at today, where she can stand up and talk the language just like you or I. Okay? We learned it together. We worked it through. We have been involved in the ethics submission, and all of the individuals that collect data in South India have taken the TCPS2 core tutorial online from South India. Because it's important that we can actually address that in ways that are meaningful to them. Everybody familiar with OCAP? Do you sit and talk about what that looks like before you begin the project that you're involved in? Some of you I see nods, but others not so much. And I guess I'm going to encourage you to think about what does that look like for the people. And data sharing agreements come in many forms, but I'm going to encourage you to think about what does that look like. Out of our most recent CIHR grant at Sturgeon Lake, we actually have developed a research protocol. And so that research protocol actually allows the community to have a better understanding of what the work is that's going to go on. And so as a result of that, we as researchers will be involved in signing off as to what we've agreed to do. I think that's terrific. I mean, I know my colleague, Anne McCauley in Ganawagi, which is another First Nations community on the South Shore of Montreal, did this a number of years ago. I've used an oral tradition for a long time, but now Sturgeon Lake was ready to actually have a new way of doing the business. So it's an opportunity for us to actually implement and apply the OCAP principles in a new way. How many of you have actually done participatory analysis regarding qualitative data? If you haven't, I encourage you to think about it. How does that and what does that look like for all of the people involved in the data collection? Because quite often we have a tendency to take it away and do it ourselves, or take it away and look at it ourselves. And the interpretation at the community level is absolutely critical. I know that when we did much of the work in the inner city, we actually had celebrations. We called them getting together and having community meetings, but they were actually an opportunity for people to look at the data and to actually feedback some information about what that looked like. The biggest thing that I see in research right now is the fact that funding doesn't include a lot of money for the community. And I encourage you to think about what you do and how you do it, because the funding for the community, if they're your partner, is usually 50%. If they're your partner. So what does that mean? That means that you need to have built in all of those things. My colleagues from Sturgeon Lake and I actually went to SAPSI, which is the Society for Academic Primary Care in UK, and we presented our work from Sturgeon Lake there this past July, which was impressive for them because they got to talk about what was meaningful to them. My research grant didn't cover it, but in fact, there was money that I had from other sources that I could make that work, but I just go, we need to start thinking about it. We need to push back as researchers so that we are actually able to facilitate having them present rather than talking about them. I've written with my colleagues from communities all around the world for many years, and I encourage you to think about writing with your colleagues, whomever that might be. They write just as well as you do, they just write differently. So maybe we need to change our writing style to actually include them and in ways that are meaningful to them, not just to us. So this is the usual kinds of things that we've talked about, and the results often drive the next research question that you've got. And as a result of that, you can identify ways that you can do that next project in new ways, because you may not have money at that point, but you do have the desire. And I'm just going to provide you with a couple of examples. The work at Sturgeon Lake that we just finished, we had a 100% response rate. Our goal was to have one household, or one individual from every household, which there are 238 households, involved in the project. And there were 238 houses that were involved in the actual project. That in itself comes with engagement. It does not come with telling. And so you can't actually do these kinds of things, the co-design, the co-production, the co-leadership, without an engagement. So I encourage you to think about what that might mean for you. And so the biggest thing for students, you need to take a step back. So I heard there were a lot of grad students over there, and the faculty and the colleges and the university needs to think about, if we're doing this kind of work, we might need a little longer. Mm-hmm. I know you don't want to be in school longer. I get that. But I also know that having done my PhD in this work, it actually is much longer up front and much shorter at the back end. So it's really concerning that, in fact, we're making it a time element rather than a good job element. So think about what that might mean for you. We need to do education, and so when you're actually training students, then we should be training the community members at the same time, regardless of the aspect of the project. So keep working on it. We all have lots of opportunities to learn. We started the Green Light program in the inner city of Saskatoon in 2008. Applied for another grant and actually rolled it out in 2010. There are currently over, this is a number that came out, it's close to 3,000 homes that are actually smoke-free in the entire province. There's 102 communities that are involved in what this is about smoke-free spaces. 3 communities have 50% of their homes that are smoke-free. That's an incredible step forward in a problem that's identified as being in underserved communities. And more importantly, all of those communities got to write about their story. So I think it's really important for us to be thinking about, how does this impact and what does that look like? Jackie remembers as we were doing this work, and certainly it's been a big rollout, and you can talk about that in just a minute, Jackie, but I just want to sort of finish up this technical piece, which it hates me now really a lot. The integration of values is the most critical element. Work on setting them and establishing them together so that when there's a problem, you can actually say, oh, I seem to have a problem, can you help me understand it? And together you can work it out versus, as Jackie talks about it, negotiating, but that's certainly what we did and what we need to continue to do as we move forward. So it has application in individuals, in communities, in organizations, and in our clinical practice in ways that we haven't dreamed about yet. So Jackie, do you want to say anything about what it's meant to you to actually be part of a research team for as long as you've been part of this research team?
I've actually had a few good things that have happened along the way, and the one thing that has really impacted me is the understanding of what it's like to be on the other side of research. What does it mean when it translates back to us as a community? I think that's been a real gift given to me, and I hope that the gift is reciprocated in the research that's done with communities. With the Green Light program, we would like to just kind of share my story about stopping smoking, and just to give you an idea, I've been smoking, I started smoking when I was 14 years old. I was a heavy smoker, I was a chain smoker for most of those years, and I really loved my cigarettes. I have to be really honest with people when I talk about my smoking, I really loved my cigarettes. And I really loved that no matter what the day presented to me, at the end of the day, I had my cigarette. And I think if people understood more clearly why people are so attached to their cigarettes are actually attached to power. and the power to have say over our own lives and over what's going on in our world. And oftentimes our power is taken away from us through various means, and so we attach ourselves to what we feel we can have power over. And one of the things that happens when you're a smoker is you have power over your cigarettes. People can try and tell you what to do. They can try and tell you what you can't do. But at the end of the day, it's your choice. And so one of the things that happened as time went on, and when I met Vivian, I have to be, I'll be real honest, I was not interested in stopping smoking at all. But as we had our relationship and as we met every week, as she says, or once a month, we met and we would go out and understanding the time, like where they still allowed smoking in restaurants, and we could meet together and I would smoke. And there were things that started to happen over time. And one of the things is I became more aware of how my smoking was affecting Vivian. So one of the first things that I stopped doing was I stopped smoking around her. I mean, we met together a few times and then you could just see it really bugged her, but she wasn't saying nothing. And so I just became more aware because that relationship of respect was there. Like, I have a deep respect for her as a person, as a human being. And she always respected my right to smoke if I wanted to smoke, and I didn't want to smoke around her. So those were kind of little baby steps that happened. And then after we were done with the surveys and we came back in the Green Light program, and that was one of the things. And I still smoked in my house. I didn't care. If other people didn't want to smoke in their house, well, great for you, but I'm going to smoke in my house. And that, again, as time went on, I started to feel like, you know what, I don't want smoking in my house, so I'm not going to smoke in my house. And my family was quite upset with me because we're all smokers. But that was what I wanted to do, and I wanted my grandchildren who were coming to the house to feel comfortable. They don't smoke, or at least not firsthand. And so, I wanted them to be comfortable. And so I started to not smoke in my house. And so for about 3 years, I didn't smoke in my house. And then I got pneumonia, really bad. I got pneumonia from mold that was in my apartment. And I'm the caretaker of this apartment building. So, but what happened was there was a leak coming down through the bathroom and it had put mold in my ceiling. And so I got sick and I kept getting sick with pneumonia. And then one night I woke up and I couldn't breathe. Just could not breathe. There's no air in, no air out. I don't know what happened. But it took quite a while for me to get some air moving. And the first thought I had was, because at that point I didn't know it was mold. The first thought I was like, I like breathing. I really like breathing. I think I'm going to stop smoking. And so it was a good thing that the mold got taken care of, because I still would have had that issue even if I had stopped smoking. So it was a good thing that the mold got addressed. But what had happened was I just realized, you know what, I don't need to smoke anymore. I'm okay. I can do this. I can stop. I can choose to stop smoking. And so I've been 5 years smoke-free. And I was a chain smoker for over 35 years. And I don't believe that if I had not been involved in the research project, if I had not been involved with Vivian, if I had not had the opportunity to see that things could be done differently and I could still keep my power and make choices over my own life, I don't think I would have stopped smoking. So that's kind of a bit of my journey, and that was one of the positive things that came out of working with communities for myself as a personal benefit. And the research that is done, I think it's important to put it out there that has actually had its rippling effects in my family. So I have people in my family, my brother who's also a chain smoker. And he's actually, he's in the contemplation stage, and sometimes he's picked up his vape smoke. And that's one thing I did do, and I still do. I don't do it very often, but I have a vape pen. It is a non-nicotine, there's no nicotine in it. It's water and grape or whatever. No chemicals in it. Those are the ones I choose to seek out if I need to do this. But this is probably the hardest part about stopping smoking, is that piece for most of us. So that helped me. And I've actually had that pacifier for about 5 years, but in the beginning, it was like I needed it all the time, and now it's like hardly ever do I ever need. But if I need it, I know that I can get up and go get one, and I don't have to pick up a cigarette or anything like that. I'll work through whatever it is I need to work through in order to stay not smoking.
Well, thank you for sharing your story around how research impacted you. And I know we're going to close right now, and then you can actually ask some questions. And I know that there's an opportunity for questions both here and after.
Yeah.
So you go for it.
Thank you both. Just gonna offer around. So we're just gonna have a few questions. Everyone's probably starving, so we'll just spend a couple minutes on questions. Does anyone have a question in the room? If you're on WebEx, type your question into the chat box and we'll bring it into the room. Questions from the in-person attendees?
I have a question. I know that within communities and within research, lots of times there's mandates in and around funding agreements and timelines and those kind of things. So if you have any advice or suggestions with some of the funding agreements that are out there that, stipulate, March 31st is the end all be all for everything to be spent and done when there's research being done. I'm just wondering if there's some advice in regards to influencing, funders in those agreements for research.
Well, all I can tell you, Wanda, is my experience with SCPOR, because my experience with CHR was amazing. I got an extra year, and that was terrific. And we are actually finished this project by the end of March this year. But the results will go on, and the questions will still evolve from that particular event. But with SCPOR, what I needed to do was be able to identify what it was that I was going to do with the additional time frame or money or whatever the case may be, and they actually would say yes or no, depending on what it was that was actually going on. But the bottom lines for me was about the community. So I received an establishment grant in 2008, and I think we actually ended in 2011, even though it was a 2-year grant. They actually extended it for a year. So I think there's some opportunities. I think it's a matter, for me, it's been a matter of being as transparent as I could be about it, and to actually then identify what I was going to use it for in moving it forward. So, I mean, just so you know, part of this is going to be, we're actually putting together a special edition for the Canadian Family Physician, where Sturgeon Lake is writing their articles, and we're going to publish them all in one book, so that they actually have a book, and the 238 homes will actually get a book. And so it's important that we actually take it back. It's that roll back to the community. So those are the kinds of negotiations that have gone on over time, from my perspective. There might be others who actually have other experiences, but that's my experience.
Maybe we'll do one other quick question, and I'm going to ask if people have other questions, so they can contact Vivian and Jackie after. Is that okay?
Absolutely.
Oh, yeah.
Does anyone else have a question?
It's not a question. I'm Brenda Andrews, and I'm a patient partner with the Saskatchewan Health Authority. And one of the most wonderful things that's going to be happening, it is exciting about is that there's going to be networks across the province of healthcare. And the nuggets and the seeds and the knowledge here today, listening to you, Jackie, and you, Vivian, is just, I can't wait to get back to the meeting next week and say, I heard some things last week at a meeting, and they all have to do around with co-creation, co-design, co-development, co-research. So I just want to say this was just the right amount at the right time at the right place, and I'm going to try to move this forward a little bit. So thank you for today. It was wonderful.
Thank you.
Thank you all so much. So we're going to wrap it up. If you're on the WebEx, you can log off now. I think everyone's probably starving and needing to eat. So thanks to everyone coming. Thanks to all the Skipper staff for helping plan the event. As a reminder, we'll be sending out a survey, so please do the survey. Lunch is served just down the stairs. You'll see the food just outside the main entrance there. So please grab your lunch and come back into your room if you still have remaining time, and meet you. Thanks so much.